go. Okay. Good evening, everyone. Thank you for joining our online CME live today from Glen Eagle Hospital, Kota Kinabalu. I'm Dr. Chong, a general surgeon, and today we have Dr. Chua Jit On, our senior consultant surgeon and head of surgical services Sabah, to share with us on the topic of serum CEA. Is it an abused tumor marker? Before we start, allow me to give you a little background of Dr. Chua if you are not already familiar. Mr. Chua graduated from University Malaya in 1990 and get his FRCS Edinburgh in 1995. Before coming to Sabah, he has served in Penang General Hospital, UMMC, and also Tengku Ampuan Rahimah Hospital Klang, among others. He has subsequently served the people of Sabah for almost 25 years now, being the head of surgical department, Queen Elizabeth Hospital, since 2001, and head of surgical service Sabah since 2001 as well. He has also a long list of publications, and in his free time, he is an avid angler. He especially enjoys deep sea fishing. Okay. If you have anything to ask Dr. Chua, please send it to the comment section and he will try to answer your question towards the end of our session. Without further ado, I will pass the session now to Dr. Chua. Good evening, Mr. Chua.
Thank you, Dr. Chong, for the kind invitation. I think it's a tiring end of the week. We are on a Friday evening before we break for the weekend. So I'm going to keep the talk hopefully short and sweet. I think it is very good that the Sabah Surgical Society and Gleneagles Kota Kinabalu have formed a collaboration to start this series of what we call Surg Talk or Surgical Talk for GPs in Sabah. For our online CME and CPD, which I think probably developed up due to the COVID, where we are unable to meet together to have our usual CPDs. Why I chose this topic today, serum CEA, the abused tumor marker, is because we do occasionally get referrals from primary healthcare physicians referred asymptomatic patients with raised serum CEA, and it becomes a big problem for us what to do with this group of patients. So I hope by the end of this talk I can convince you all not to do serum CEA as a screening tool or a tumor marker, tumor marker for the diagnosis of colorectal cancer. So the content of my talk will go through the subtopics. I will start with introduction, the sensitivity of CEA, the specificity of CEA, what should serum CEA be actually used for, and if CEA is accidentally screened, how far should we go to investigate these asymptomatic patients, and finally the conclusion of this talk. Introduction. Okay. CEA is also known as carcinoembryonic antigen. It was first isolated in 1965 by Gold and Friedman and was isolated from human colorectal tissue. What they found was CEA was found high in fetus, because it's a fetal glycoprotein that is produced in developing gastrointestinal tissue. And CEA levels drop upon birth. Adults have a low level of circulating CEA, and normally the level is less than 5 nanograms per milliliters. The use of CEA in colorectal cancer population screening has been, I think, previously investigated extensively and has been found to be inefficient. It has low sensitivity and specificity, and it is not recommended in most guidelines, in most clinical guidelines, to be used as a diagnostics tool or as for screening for colorectal cancer. Surprisingly, there are some papers that show that the levels of CEA does somewhat correlate with the tumor stage, prognosis, and extent of surgical resection of colorectal cancer for individual patients. I will go into this a bit more detail later. Unfortunately, serum CEA has been used, or rather I prefer the word abused, as a tumor marker in health screening packages for asymptomatic patients for colorectal cancer. I think you go to a lot of health labs, a lot of times when the people do a health screening for for patients, Serum CEA is always included in part of this health screening as a tumor marker or to screen for colorectal cancer. But actually this is not the correct way of using Serum CEA. This results in a lot of referrals to either surgeons or gastroenterologists for scopes, for endoscopic evaluation, for what we call a raised CEA when the level of CEA is above 5 nanogram per milliliters. You have to understand that this has significant implications for rising health costs and patient anxiety. You see, once you have a CEA raised, then you create an anxiety in the patient that they may possibly have colorectal cancer. And they are referred to either surgeons or gastroenterologists for further assessment, normally involving endoscopic evaluation, which is not cheap to be done in a private setting. And patient is anxious, and the worst thing is when the scope findings come back as negative, then what is the cause of the CEA? So it creates a lot of anxiety for patients when the serum CEA is raised. Sensitivity. Okay, serum CEA is not sensitive for colorectal cancer. I hope I can convince you in the next few slides. Okay, it is not sensitive because serum CEA is only found in about 17 to 47% of colorectal cancer patients. That means out of say 100 colorectal cancer patients, when we do serum CEA for them, only 17 to 47 of these patients may have raised serum CEA. That shows that it is not a sensitive test for colorectal cancer. Normal serum CEA levels does not mean that if the serum CEA levels is normal, this does not mean that the patient does not have colorectal cancer. So if you do a health screening and the serum CEA level comes back as normal, it gives a false sense of security to the patient, because you tell the patient may not does not have colorectal cancer, which is actually wrong. If these patients actually have symptoms that may suggest colorectal cancer, and you have the normal CEA level and you tell them they don't have colorectal cancer, it may delay them from getting the diagnosis of the colorectal cancer or treatment of the colorectal cancer. Therefore, a normal serum CEA level does not rule out a presence of colorectal cancer. You look at this interesting slide done in Japan. This is the stage of the colorectal cancer and tumor markers. The one I've put under the regs box is the level of CEA. You have from stage 0, stage 1, stage 2, stage 3 and stage 4 of the cancer. You notice that the sensitivity of CEA is different in different stages of colorectal cancer. You look at an early stage, the sensitivity of colorectal cancer is only 10%. Whereas in the late stage, stage 4, the sensitivity of colorectal cancer, CEA for colorectal cancer goes up to about 66.7%. It tells you that CEA is not a good screening tool. Why? Because in early stages, it does not pick up colorectal cancer. It's not sensitive. Whereas in late stages, it's a bit more sensitive, but it's too late already. In a screening test, when we do a screening tests are supposed to pick up cancer at an early stage so that we can allow the patient to undergo prompt treatment and better survival. If you pick up a cancer at stage 4 and you can't, the management is more of palliative, then it defeats the purpose on the principles of cancer screening. So CEA only picks up colorectal cancer when the cancer is at a later stage. Specificity. Okay. When you look at serum CEA specificity, serum CEA levels more than 3 to 5 nanograms per mil are deemed to be elevated. However, when you look at the baseline levels of CEA, the baseline levels are usually higher in males, higher in smokers, and also as you grow older, the serum CEA levels goes up slightly. CEA levels more than 10 nanogram per milliliter or trending upwards are more commonly associated with malignant conditions. So a single reading is not as accurate as if you do a trend, and the trend shows that the CEA is rising up slowly. And levels of more than 20 nanogram per mils are usually suspicious for metastatic disease. Okay, you look at this graph. For what you call that, smokers and non-smokers, you see there's a difference between the baseline CEA levels, and as you grow older, the level of the CEA grows up. So that means smoking increases CEA levels, and serum CEA also increases with age. As we age, it will go up slowly. Serum CEA is not specific for colorectal cancer. It can be elevated in other malignancies, especially those from epithelial origin. It can also be elevated in non-malignant diseases, as CEA is primarily metabolized in liver. Hepatic dysfunction and biliary disorders can be associated with raised level of CEAs. Look at this chart. Okay, what are the conditions that CEA may be elevated? Okay, non-malignant conditions: smoking, infections, peptic ulcer disease, inflammatory bowel disease, pancreatitis, hypothyroidism, liver cirrhosis or hepatitis, benign breast conditions, other benign tumors usually in organs where the cancers are associated with raised CEA. In malignant conditions, which are the tumors that are associated with a high CEA expression: colorectal cancer, ovarian cancer, cervical cancer, lung cancer, esophageal cancer, gastric cancer, small bowel cancer, hepatobiliary cancers, pancreatic cancer, breast cancer, medullary thyroid cancers, and other CEA expressing tumors including choriocarcinoma, osteosarcoma, retinoblastoma, hepatoma, melanoma, lymphoma, urinary bladder, prostate, and renal cell carcinoma. So you look at it, if you do a serum CEA, the serum CEA is elevated, it does not mean that the patient has colorectal cancer. It's only one of the cancers where serum CEA may be elevated, and there are so many other cancers that may express high levels of serum CEA. So what should serum CEA be used for actually? Okay, the common clinical use of serum CEA in clinical practice, especially in the surgical setting, is surveillance for recurrence of colorectal cancer, and not in the diagnosis or screening for colorectal cancer. Serial monitoring of serum CEA levels can detect tumor recurrence prior to clinical or radiological evidence of disease. So normally in colorectal cancer patients, the serum CEA after treatment is monitored in certain centers 3 monthly, in certain centers 6 monthly, and an upgoing trend normally predicts the possible recurrence of the colorectal cancer. What else is CEA has been used for? Okay, there has been studies that show that pre-operative CEA levels do correlate with the prognosis of the patient with colorectal cancer. Quite a number of papers shows that serum CEA predicted overall survival across stage 1 to stage 3 colorectal cancer, with elevated pre-operative serum CEA carrying about a 62% increase in the danger of death compared with patients who had stage 1 to stage 2 colorectal cancer with normal CEA levels. So in patients with pre-operative colorectal cancer where the CEA levels are high, actually it carries a poorer prognosis. The 5-year disease overall disease survival was about 84% versus 69%, and 74% versus 63% compared in patients without raised CEA versus those that have raised CEA pre-operatively. In colorectal cancer, elevated in the rectal cancer, elevated pre-treatment CEA levels are associated with a poor response to neoadjuvant treatment, with the retrospective analysis of patients of stage 1 to stage 3 rectal cancer showing significantly decreased pathological complete response, pathological tumor regression, tumor downstaging, and overall survival with patients with elevated CEA after they receive neoadjuvant chemoradiation. Post-operative CEA and prognosis. Okay, serum CEA level controversial. Okay, there are patients that show that an increasing or progressively rising CEA levels with previous colorectal cancer should be investigated for recurrent disease. The threshold for serum CEA used to trigger further investigation is controversial, with some people using 5 nanograms per milliliter, some people using 10 nanogram per milliliter. But in most papers or in most guidelines, they conclude that actually the level of 10 nanogram per milliliter should be used. It's probably more more accurate compared to the level of 5 nanogram per milliliters. But the funny thing is, even though the rising CEA levels, the recurrences were detected earlier, can be detected earlier compared to imaging studies, the meta-analysis actually show there is no survival benefit with increased surveillance after resection of colorectal cancer. That means even you can pick up the recurrences or the metastasis early by noting that the serum CEA is going up, but whether it's detected early or late after treatment, the survival is actually the same. There's no significant survival benefit. So, for CEA use as screening, how far should we go? What I mean by how far should we go is, although CEA should not be used as a screening tool, we still get a lot of referrals from primary healthcare physicians and clinical laboratories that run health screening protocols that incorporate CEA as part of the health testing package for individuals, usually asymptomatic individuals that go for their usually yearly or 2 yearly so-called medical healthcare check. The problem always comes when the serum CEA level is raised and they are referred to us. Now, when they are referred to us, how far should we go to investigate the patient when their CEA levels is raised? This is a very interesting paper by a Singaporean group that was published in 2009, where they looked at a cohort of 217 asymptomatic patients that were referred to them for raised CEA. These patients were followed up for about a median of 13 months, that means about a year plus, with a duration of some being followed up from 6 months, some being followed up for 97 months, and patients were recruited from 1998 till 2004 in Singapore. So this is a group of Singapore doctors that decided to do a retrospective studies of what happened to these 217 patients that were referred to them for raised CEA when these patients were so-called asymptomatic. The reference value used in this particular study was at a level of 5 nanogram per milliliters, and interestingly, out of these 217 patients that were referred, 28 of these patients were found to have a malignancy at the initial investigation. That means about 16.59% of these patients had cancer after the initial investigation, and 8 out of 28 of these patients already had metastatic cancer. That means a late stage of cancer. When you look at what they found out of these 270 patients, what the investigation they normally do is they will normally take a clinical examination, physical, history taking, physical examination, the standard examination. Then patient majority will undergo endoscopic, investigation, OGDS and colonoscopy. Some will undergo chest radiograph and CT scan. Some will undergo ultrasonography of the abdomen or CT of the hepatobiliary system. Some, a small proportion will undergo mammogram. Some of these investigations are decided based on the history and physical examination of these patients. And you look at it, out of these 217 patients that were screened and had a high CEA, usually we use a CEA to look for colorectal cancer. Out of these 28 patients that were found to have cancer, only 11 had colorectal cancer. That means majority of the cancer found are actually not colorectal cancer. That tells you that serum CEA is not a sensitive test for colorectal cancer. They have found stomach cancer, benign ulcers, gastric polyps, gastric inflammation, benign polyps in the colon, colonic inflammation, colitis, pulmonary fibrosis. Quite a number of patients actually had primary lung cancer, lung metastasis of unknown origin, primary periampullary cancer, liver metastasis, ovarian teratoma, and many other cancers. And out of these, 20 were primary cancers, 8 were metastatic cancers. So it tells you that when you say metastatic cancers, means the level when a CEA is raised, this already tell you that it is not a good screening test because it picks up cancer when they are already at a late stage. And what they did is most of these patients, they followed up for another 2 years, monitoring the CEA level and also the patient. And within that 2 years, they found out another 16 primary cancers, about another 7.4% of cancers. Again, you look at it, none of these patients follow up later had colorectal cancers, but they had cancers elsewhere. Stomach cancer, lung cancer, liver cancer, ovarian cancer, prostate cancer, nasopharyngeal cancer, periampullary cancer, and a medullary thymoma. It's interesting to note medullary thymoma is actually not associated with any increased CEA, because due to the raised CEA and this patient will follow up for vigilantly for 2 years, they incidentally found that this patient had a medullary thymoma. But this is not, this tumor is not associated with a raised CEA level. Okay, so because of this study, what they did is they proposed an algorithm what to do if patients were referred, asymptomatic patients were referred to doctors with raised CEA when they had a health screening done for them. Okay, so their algorithm is first, as all patients that we see, full history taking, physical examination including medical and smoking history, a thorough breast examination especially for females, abdominal examination, and do not forget a digital rectal examination. Then a majority of these patients will undergo OGDS and colonoscopy. Subsequently, a number of them will undergo CT scan or ultrasound of abdomen, chest X-ray or CT thorax, and they will follow up with a repeat CEA. They will probably some will do 3 monthly, some will do 6 monthly, up to about 2 years. If the patient's CEA remains goes down or remain normal or do not elevate, then they discharge the patient from follow up. But when you look at this algorithm, the cost of of investigating a patient with raised CEA is not cheap. Okay, OG and colono, if you've done in a private site, it's a few thousand already. If you have a a CT abdomen or CT thorax or thorax abdomen pelvis, that will cost another few thousand. Further follow-ups, in the clinic, and a repeat of CEA also will cost a fair bit of it will cost a patient a large amount of money. So, but when you look at it, a lot of people sometimes truncate the investigation at OGTS and colonoscopy. I think it is not adequate to truncate the examination. They say, for example, a patient has a CEA, you do an OGD and colonoscopy, it's normal, then you tell the patient there is no cancer, you can discharge the patient from follow-up. I think this is not adequate, because you look at the previous slide, colorectal cancer actually is not the bulk of cancers. There are many other cancers that that is not ruled out with the basic colonoscopy or even OGD to rule out stomach cancer. There are a lot of other cancers that is not ruled out by just doing an OGD or colonoscopy. Actually, in my own practice, I've picked up a fair number of lung cancers in patients with raised CEA when the OGDS and the colonoscopy is normal. So for me, my algorithm for my patients normally is full history taking and physical examination, normally followed by standard OGDS or upper endoscopy, a colonoscopy as the first line. And if this OGD and colonoscopy is normal, normally I will get a CT abdomen and thorax, or what you call a CT-TAP, thorax, abdomen and pelvis. Normally I will do that. Okay, if the OGD and colonoscopy is positive, then obviously we move towards the management but if this is negative, then I will normally go towards CT, thorax, abdomen, pelvis. If this turns to be normal, then normally I will follow up the patient. In my own practice, I normally follow up for 2 years, and I repeat the CEA. For me, I do not repeat that frequently. I normally do it about 6 months. So that means patient will have a 6-monthly CEA up to 2 years. If they remain well and asymptomatic in history, I do not repeat the scans. Although in this patients, they repeat the examination at 2 years. Okay. For me, I don't repeat unless the level is going up or it remains high. Then I may repeat at a 2-year interval. This is another algorithm done from a meta-analysis from New Zealand and UK group. Theirs is even more, I think, exhaustive compared to the Singapore group. Okay, so when a patient has a raised CEA, they do a clinical review. Okay, if it is negative, they will ask the patient. If the patient is a smoker, they will ask the patient to cease smoking. They'll do a 3-monthly CEA assessment and clinical review. If the CEA goes down consecutively, after 6 months, or normalize with a CEA less than 10, they discharge the patient. If the CEA remains high or goes up, they will do PET CT. Okay, if the clinical review is negative, then they will do organ specific investigation. Organ specific investigations include the upper lower scope, CT scans of various parts of the body depending on what the patient complains of. But if it's negative, they progress to PET CT. I think in the Singapore group, we don't do PET CT. PET CT is not freely available and is very costly to be done for patients. So theirs, when you compare their algorithm compared to the Singapore group, theirs have an additional of PET CT before they rule out a patient as negative, and they still monitor the patient with serum CEA levels 3 monthly. So when you look at the headache that you cause the patient, if you do CEA as part of the health screening, it really creates a big headache for a proportion of patients. If you look at the previous slides, okay, so if you say that if you include initially about say 16% of patients found to have cancer, plus another about 7.4%, so we add it up together, that means will be around 23, maybe about almost a quarter of patients may have cancer if the serum CEA is used as a screening test. But it goes against the principles because a majority of these cancers are actually detected at a very late stage and not early stage, and that defeats the principles or the purpose of doing a screening test where you want to pick up cancer at an early stage. Actually, the recommended screening test for colorectal cancer is actually stool for occult blood. If you say a population screening for colorectal cancer, the standard or the recommended test for screening for colorectal cancer is actually stool for occult blood. So that is almost ending to my talk. So I would like to conclude my talk in saying that CEA is neither a sensitive or specific diagnostic tool or screening tool for colorectal cancer. It should not be abused as a screening test for colorectal cancer. It only should be used in our clinical setting for monitoring and management of colorectal cancers that has already been diagnosed. Thank you, and I welcome any questions from the audience.
Okay. Thank you so much, Dr. Chua, for your sharing on the possible abuse of CEA and its impact on the clinical healthcare resources. We'll take 1 minute's break before we move on to Q&A session. Please send in your question in the comments section. Welcome back, and thank you once again for joining us in this surgical talk session. We have a few questions coming in. Let me see. Okay. From Dr. Reza. Can I know how often should we repeat CEA for monitoring a diagnosed and operated colorectal cancer cases?
Okay, in most guidelines, monitoring of CEA levels are either done 3 monthly or 6 monthly. Certain countries do it 3 monthly. Certain countries or certain guidelines advise to do it 6 monthly. For Malaysian guidelines, majority of the colorectal surgeons will do the CEA levels 3 monthly post-operatively for the first 2 years, subsequently 6 monthly. Okay. I think as mentioned earlier in my earlier slides, even though you do the the levels either 3 monthly or 6 monthly, and you can pick up the recurrences early, majority of studies show that there's actually no survival benefit whether you pick up the recurrences early or a bit later. I think there's a paper I quoted that they can pick up the recurrences about 6 months earlier than picking up the recurrence clinically, but the overall survival, whether you pick up it 6 months earlier or later 6 months, the survival is actually similar.
Okay. All right. We heard in Dr. Chua's talk that he's been stressing on how CEA should not be used without clinical correlation, as in many screening packages. We have a question from Dr. Joey that says, is it same for other tumor markers as well as blood tests for health screening packages, and mostly in private sectors usually include all tumor markers?
When you look at the most recommendation or most guideline recommendation, the only tumor marker that has been recommended to be used as a screening tool is actually the serum PSA or prostate specific antigen. The rest of the tumor markers are actually not sensitive nor specific.
Okay, we have another question. This one is from Kian Keroro. Hi Mr. Chua, I have a patient previously CEA level 15, done OGDS colonoscopy, results are normal. He repeated his CEA after a year, raised to 30. Otherwise clinically he is well. Does this case indicate a referral or further investigation?
Yes, you see, as I mentioned in the earlier slides, there are many other cancers that can cause a raised CEA level, and a CEA level more than 10 nanogram per milliliter is very suspicious of cancer, and level of more than 20 is highly suspicious of metastatic cancer. You have to remember, as I showed you in the earlier algorithm, OGDS and colonoscopy is not adequate to diagnose cancer if the patient have a significantly raised CEA. If the OGDS and colonoscopy is negative, this patient should be further investigated with, for me, I will do a CT of the thorax, abdomen and pelvis, and also to take a good clinical history and physical examination before you rule out that this patient has no malignancy. Because I'm sure in this talk, you have seen the slide I've shown, colorectal cancer actually is a small proportion of patients that actually have cancers when the CEA is raised. There are many other cancers that can cause CEA to be raised. So in your patient, I would refer him urgently to either a physician or a surgeon for further investigation to investigate the CEA. The CEA level of, I think you mentioned 30, is it? Yes. After 30 is highly significant. I hope that answers your question.
All right, let's see any more questions. We still have time for some further questions. If you have any question, please send it to the comment section.
I thought the anemia question. Never mind, you read out.
Okay.
I see if I can.
All right. Next question. Dear Mr. Chua, if CEA is elevated in an already suspected or diagnosed non-GI malignancy, for example, ovarian CA, does it indicate any possibility of colorectal mets?
As I mentioned, if it is not colorectal cancer, the usage of CEA to monitor other cancers is actually not recommended. It is only meant for monitoring of patients that already been diagnosed with colorectal cancer and have been treated for the colorectal cancer. If the patient has ovarian cancer and you are following up for the ovarian cancer, please do not use CEA as a monitoring tool. It creates the headache again when the CEA is raised. Now you don't know whether is the CEA is raised due to the recurrence of the ovarian cancer the patient has, or is due to something else, and you create the headache again, almost similar to the condition where a patient that's asymptomatic and have a raised CEA level. So I think if your patient with the ovarian cancer treated and somehow got a CEA done and is raised, I will go through the same algorithm that has been done for the asymptomatic patient with raised CEA, at the same time also to monitor whether there is a possibility of that ovarian cancer recurring.
All right. We have one more question. In colorectal cancer, CEA has been used as a prognostic tool. Does low CEA level always mean better prognosis compared to high CEA level? This is by Dr. Eugene Ma.
Okay. When you look at CEA levels, as I said, quite a number of studies that show that the CEA levels are higher, the prognosis is poorer. But I also have shown that there are some studies that have shown that it is not actually correlated. A good example I can tell you is, for example, sometimes we have poorly differentiated versus well differentiated tumors. Poorly differentiated tumors are normally more aggressive and carries a poorer prognosis. So a proportion of patients that have colorectal cancer that is poorly differentiated may not have the CEA level being raised, because a poorly differentiated tumor do not resemble the original tissue. Therefore, the level of CEA in this group of patients may not be raised. So it may not be that useful in patients with to prognosticate patients with poorly differentiated colorectal cancers. For well differentiated colorectal cancers, yes, it may have some value in prognostication, but as in medicine, nothing is 100%. Okay, not all patients with high serum CEA has poor prognosis. Not all patients with normal serum CEA with colorectal cancer have good prognosis. You have to follow up the patients with multiple investigations and assessment, and not base it on serum CEA alone.
Okay. Dr. Chua has mentioned that the appropriate screening tool for colorectal cancer should be fecal occult blood test, and we have quite a number of referral from klinik kesihatan, but not many from the private primary care. Any idea why is it so? It should be readily available, right?
I think the problem is a lot of overseas countries actually have population screening for colorectal cancer. For certain countries, anybody above 50 years of age, the government will instruct or provide services where patient will have screening for colorectal cancer. That means they will undergo a test for stool for occult blood on an annual basis. But in Malaysia, I think we do not have this population screening program for colorectal cancer. And recently, I think in the past few years, they have initiated, but only in selective, primary healthcare centers where stool for occult blood is done for asymptomatic patients that are above 50 years old. Okay, so I think it probably have not caught on in the private sector yet. Okay, actually stool for occult blood is not that expensive, and if it's done, I think it's a good screening tool for colorectal cancer. But sometimes I find that it is not used properly. We have had referrals where patient had per rectal bleeding, weight loss, had anemia, and had stool for occult blood done as a screening tool and referred to us. Actually, if the patient is already anemic or had per rectal bleeding, that is already an indication for endoscopic assessment. You do not have to do the stool for occult blood, especially if patient have a gross per rectal bleeding. Stool for occult blood is you are trying to look for rectal bleeding. If the patient have obvious rectal bleeding, there's no point doing a stool for occult blood anymore already. Patient should already have been referred for endoscopic assessment.
Okay, I think our audience are just getting warm up. There are more questions coming in.
Oops.
Okay. Hi, Mr. Chua. For asymptomatic patients more than 50 years old with persistent Ray CA, however, initial OGDS colonoscopy and other investigations were negative, how soon would you suggest to repeat the OGDS colonoscopy? This is by Ng Yun Jet.
Right?
Dr. Ng Yun Jet.
Okay. When you look at the protocol, okay, show back the protocol, it's easier. Okay, when you look at the Singapore protocol, where when they did asymptomatic patients, then if the initial investigations are negative, they follow up with repeat CA for 2 years. Okay, so if the CA trend is coming down, then it's not necessary to further investigate. If the CA level is going up, then we may need to investigate. The Singapore group, because it's a retrospective study, some of the clinicians do the CA 3 monthly, some do it 6 monthly. My own personal practice, I normally do it 6 monthly because I feel that 3 monthly is too early, and repeated scopes sometimes may cause more harm than good. So if I repeat the CA level at 6 months, if the CA level drops and the clinical examination and history does not suggest any malignancy, I do not repeat the investigations. Okay, but if the CA levels remain same or goes up, I will repeat the OGD and the colonoscopy in 6 months time. I mean at the 6 months after that, if the CA show is high, if this is negative, then I will proceed with the CT thorax, abdomen and pelvis. Okay, and if that is negative, I stop at that and I will repeat another CA level 6 months later. In female, be very careful. Do not forget breast. Do not forget to examine the breast. Normally, if you have done a CT thorax, abdomen, pelvis, any breast abnormality or lesions normally will be picked up by the CT thorax.
Okay. Due to the time constraint, we will allow for one last question. It is from Dr. Shirley Chong. Thank you, Mr. Chua, for the sharing. I would like to ask regarding stool occult blood test. If primary care taking it for all patients with anemia, is it considered an abuse as well? And second part of the question, how about another setting in critical care with sudden drop in HB without evidence of bleed?
Okay, a patient that presents with anemia, okay, should receive treatment for the anemia, and the anemia should be investigated. So it doesn't mean that a patient with anemia should have a stool for occult blood. Stool for occult blood may be part and parcel for workup for anemia, especially the anemia is shown to be microcytic hypochromic anemia. If the anemia is megaloblastic anemia, then I think the stool for occult blood may not be necessary. So if the patient has anemia, they should be investigated further for the anemia based on the type of anemia, and stool occult blood may be part of the investigation and may not be part of the investigation depending on the type of anemia. Hypochromic microcytic, yes, then normally a stool for occult blood will be indicated. Okay, the second part of the question is what now? Can you remind me again?
Yeah, the second part is actually not so clear. She asked that how about another setting in critical care with sudden drop in HB without evidence of bleed? I guess that means
If you say patient come in with a sudden drop
drop
of
in
bleed,
HB.
patient hypotensive and tachycardic, I think that is what you call that, stool for couplet is not part or parcel of the examination. That means acute bleed. If we say in a critical setting, acute bleed normally is bleeding in hidden spaces. For example, either in the intrathoracic or intra-abdominal cavity, or patient have trauma and a BPA drop, then you look for hidden fractures, long bone fractures or pelvic fractures. I think stool for couplet is not commonly used in a critical or acute setting. It's normally used when the patient presents with more of a chronic anemia.
Okay. That was the last question for today. Dr. Chua, do you have any last remarks for our viewers today?
Okay, I hope that my talk has given you all a clear indication of when to use Serum CEA, and I really hope that this Serum CEA should not be used as a screening tool for asymptomatic patients in the future. Thank you.
Thank you once again, Dr. Chua. To all doctors, please don't forget to scan the QR code at the end of this live session by using your MMA Doctor Phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link for doctors only in the comment section to confirm your attendance manually. Stay tuned for many more surgery talks in store for you throughout 2022 by the Sabah Surgical Society in collaboration with Gleneagles Hospital Kota Kinabalu, due to be given by the various surgical subspecialists in Sabah. Let me know if you are interested. We will share the details with you. Okay, we have come to the end of our online CME today. Thank you very much for watching and listening to us, and see you next time.
Thank you. Goodbye.